For repairing the pasta lesion, important is a good technique, but most of all, a good selection of the patient. I like the triple-loaded ThRevo, the FT, full-threaded, because with the 3 sutures and of course the metallic tip, I can go easily through the tendon, the remnant tendon, without harming it too much. I mean, if you screw it in, you are not making a hole that is 5 millimeters. You just go in between the fibers, and the hole is very minimal, just enough to have the suture go through it. The other little system that I use, I don't use any aggressive suture passer to retrieve the suture. I like very much a simple spinal needle. A spinal needle is not harming the tendon. You can send by hand any kind of monofilament or a shuttle relay if you wish, and make your repair very precisely and without any major harm to the tendon that you're going to repair. I have the scope in the posterior, classical posterior portal, and we created an anterior portal too, where I put a small cannula. I go behind the biceps, and what I see here is that we have a partial articular side tear of the supraspinatus that is usually called pasta lesion. The greater tuberosity is exposed with no tendon attached, and we know that the thickness of the tendon here is roughly around 12 millimeters. 1 millimeter should be deducted for the so-called rim rent, so we have 4 or 5 millimeters tear in this area. That means close to the 50%. You notice that the pulley is preserved, so I'm not going to treat the biceps itself. I will simply repair in this area. Now, I will do an in situ repair of the pasta lesion. With my spinal needle, I want to be sure that the acromial lateral overhang is not impeding a proper angle of approach. As you can see, I can reach very easily, so I'm happy. And now it's time to go in the subacromial space. So I remove my scope and I take my blunt trocar and I go in the subacromial space. We have a lot of bursitis, and imagine if you do not clean this before starting the procedure, when you will move in this area in the subacromial space to retrieve the suture and tie the knot, you may waste a lot of time. Just make all the steps one after the other without rushing. The spinal needle is indicating where the tear is. We were exactly here, and we want to be sure that we don't have any damage in this area, and we don't. We can make some internal, external rotation, check if the ligament is frayed or not, and it seems to be very smooth. And we are happy we can proceed for our intra-articular time. So we are now back in the joint. So this is again the pasta lesion. We abrade the bone. We also clean a little bit the tendon. Once you get good bleeders coming from the bone, then you're happy and you can proceed with your repair. Now it's time to aim with the spinal needle. I think this is a very good angle of approach here. Now I need a switching stick just to have a little dilatation of the muscle, and I will simply follow my spinal needle in order to fall in the proper position. Then in this case I take a triple-loaded, fully threaded anchor that is called ThRevo FT, full threaded ThRevo. So I screw nicely through the tendon, so I'm not making any big hole in this area. Now I can remove the spinal needle and complete the full insertion of the fully threaded triple-loaded anchor. Then you take the mallet just to start up the introduction, and then complete the screw in. We will have the laser mark coming into view, telling us that we are deep enough. Now I can release the sutures. With the mallet, gently and nicely remove the inserter. I pull snugly in order to be sure that I'm not having any pull out. And now a little simple trick. I push in the joint my inserter in order to lock the 3 sutures and not to have to fight to retrieve those up there. Now I take the 3 different colors. I have white, blue, white, black, and all white. So the 3 sutures are in position. At this time I can remove my inserter, ask my assistant to pull the other sutures, and you see that this makes much easier suture retrieving. Now it's time to pass my suture through the tendon, but the first step is retrieving one limb, whatever is the color. Once you have one limb in the cannula, the spinal needle is your suture passer for the pasta repair. Ideal, minimally invasive. You go through the skin, through the deltoid, and then through the good rotator cuff. You take a shuttle relay and you send it in by hand. Take a grasper and retrieve through the anterior portal. Now place a few inches of your suture that you retrieve through the anterior portal in the eyelet, and then pull. We retrieve the first suture through the tendon. This is suture number 1. It's time now for the second one. We will take the white one, keeping an eye in order to avoid unloading the anchor. And again, I come with the spinal needle a little more posterior, and I can send my shuttle, and again, take the eyelet, load the suture, and retrieve it through the good tendon. Now it's time for the third suture, that is the black and white, to retrieve the third and possibly final suture. Now we have 3 sutures passed to the right tendon, and with the same technique we can place a second anchor if needed. We can eventually do a mattress plus 2 simple. You can play with the suture in many different ways, but the principle and the technique is the same. In this case, we just go in the subacromial and we start tying the knots. If I have a good orientation, then I create my lateral portal. This is the anchor, the most anterior suture, the intermediate, and the posterior. Now we start from anterior to posterior. I retrieve the 2 same color limbs, and I take as a post the suture that is coming out of the tendon, not from the anchor itself. And we are ready to perform any kind of sliding knot that you may like. Leave the loop alone and pull on the post in order to avoid early locking of the knot. 3 half hitches in order to completely lock the knot itself. Twisting my tension so that I am locking in the proper position my knot. Now we can cut the tail using the katana, and the first knot is done. You can tell the compression that you are getting for your tendon. Now we go for the second suture, the intermediate one, and we tie the second knot. The first sliding, as usual, we make a few half hitches in order to really lock it. Now it is time for the third suture that we are going to tie. Okay, then we are happy and we can cut. And we completed our repair. And you can tell the tendon is very nicely compressed down below. So this is the lateral view. Again, this is the most anterior, intermediate, posterior, and you see that they converge over the anchor that is down there. And you can tell easily that we got a good tendon reattachment from this side. So now we are back in the joint. This is the biceps. And where is the pasta? Not anymore. You see that the repair is very anatomical. We restored the footprint, and it was not a complicated procedure and not aggressive for the soft tissues and for the patient.